Thank you, Ambrose. Oh, I think I need to adjust this slightly. I'm sorry I have to do this in English. First of all, I'd like to thank the organization for inviting me to do this presentation. I will be talking to you about a research trial that we are hoping to conduct in the near future, which will involve the use of injectable buprenorphine for the treatment of heroin addicts who are persisting to inject street heroin whilst in standard opioid substitution treatment. First of all, a few words about myself. I work in the South London and Maudsley NHS Trust in the Addictions Division. I conduct and coordinate clinical trials, and I would also like to say that I'm currently undertaking a research project that is funded by Reckitt Benckiser. Before I go into the details of the actual project, I would like to provide a bit of background. Yes, there it is. Now, Wim has already sort of explained some of the ins and outs of injectable opioid treatment. I'll briefly mention it again. It has been known that some people in conventional oral substitution treatment, for example, oral methadone or sublingual buprenorphine, persist in injecting heroin and other street drugs, often resulting in multiple unsuccessful treatment episodes, and that includes people going through rehab or detox, high levels of crime, and poor health and social functioning. Randomized controlled trials have reported that supervised injectable opioid treatment, IOT, can help retain people in treatment, reduce street heroin use, and improve health and social functioning. In the UK, following the success of these trials and the introduction of supervised injectable opioid treatment in Switzerland, a clinical trial was conducted in 2005 called the RIOT trial, stands for Randomized Injectable Opioid Treatment Trial, which ran for about 3 years and was successful. It also encouraged the then government to support the introduction of injectable opioid treatment on a supervised basis as a treatment for people who persist in street heroin use whilst in treatment. Therefore, it's available as a second-line treatment. Now, in the UK, it's probably slightly different from other countries, so I'll talk you through it, what it actually means. There's two options available. People can either be prescribed diamorphine ampules or methadone ampules. Sorry. What is the major difference? Well, diamorphine ampules, it would be on a supervised only basis, and people could attend on 7 days a week on 2 times a day. So it is limited in that sense. Therefore, people will receive an additional dose of oral medication, and that is usually oral methadone, but in some cases, controlled release oral morphine is provided, slow release oral morphine. For the methadone ampules, that people would not need to attend more than once a day, but because we noticed that methadone ampules do not always hold people comfortably over a 24-hour period, additional oral methadone is also available for that group. Despite the encouraging results of both arms, there are some drawbacks involving the use of injectable diamorphine and methadone, and I've just summarized them briefly. I'm sure there's a more extensive list. But in the case of diamorphine ampules, oxygen desaturation has been well reported following injection of heroin use and the risk of hypoxia. There's a higher frequency of attendance. Attending up to 2 times a day for 7 days a week can be quite challenging, and it also results in higher costs of the treatment. The methadone ampules has the benefit that it's only once daily. However, it has been reported to us that when injected intravenously, people mention a stinging sensation, And there are also complications when it's administered intramuscularly, and therefore it's unpopular with most patients. I thought I'd put in a little slide to explain about the oxygen desaturation. This is a 49-year-old man who was in one of the patients in the Riot trial. And although he had been in treatment for about 6 years, you can see that there was quite a significant drop in oxygen saturation following the administration of the intravenous injection. This slide is to tell you about the proportion of methadone ampules in all methadone prescriptions, and as I said, it's less popular. And you've noticed that from about 10% in 1994, it drops to about 1% in 2008. So therefore, if we keep in mind the drawbacks of injectable diamorphine and injectable methadone, the question is, would injectable buprenorphine be a suitable alternative? A couple of things. When we looked on our database for the whole trust, we noticed that there's quite a significant number of people that were prescribed sublingual buprenorphine and who continue to inject street heroin. And previously, those people would be asked to convert to oral methadone to be able to start supervised IOT. Now, if you take into consideration people might be on quite high doses, you can imagine that would be quite a challenge. First of all, for people to reduce to a level where they can switch, and it may actually put a lot of people off. So for that group of people, and in general, buprenorphine ampules may provide better treatment options for those patients. So what we would like to know about injectable buprenorphine? Well, first of all, is it actually something that people are interested in? And would it deter people from injecting street heroin? Would it be sufficiently reinforcing for people to attend on a daily basis? And very importantly, would it be safe? So more comprehensively, the study will examine whether subjects not responding to conventional substitution treatment will remain in injectable buprenorphine treatment and will reduce their use of non-prescribed opioids. In addition, the study will investigate subjective and physiological responses to injectable high-dose buprenorphine and will investigate responses across a range of doses. The primary objective, I've sort of mentioned that before, feasibility of recruiting and maintaining people, reduction or cessation of injecting street heroin, subjective and physiological responses, optimal dose range of injectable buprenorphine. There is some evidence that in high doses it might actually have an antagonist effect. The safety of injectable buprenorphine, and we would also like to ascertain appropriate power calculation to conduct a full randomized controlled trial in the future, obviously if this trial is successful. We are looking for 10 participants who are in buprenorphine treatment for a minimum of 3 months at the time of screening and have been for a total of 12 months on either methadone or buprenorphine treatment in the past. We were looking for people who would persist in injecting heroin use on more than 3 days a week, as evidenced by urine drug screen, client self-report of regular injecting heroin use in the preceding 3 months, and of injecting heroin use on at least 50% of days in the past month. And people cannot have any significant liver and or respiratory disease. The trial would take place at the South London and Maudsley Supervised Injecting Clinic. This was one of the sites that was involved in the randomized injectable opiate treatment trial. And people would be attending daily for supervised administration. I should say that which is quite important, that if people would be unable to attend, they would be able to have access to oral buprenorphine. At the respiratory unit at King's College Hospital, people would have extended respiratory monitoring on day 108 and 183. The design of the study, we're looking at 3 stages. First of all, titration. and I've put it in a bit more detail here. I would have to say a few words on why we've chose these doses. The bioavailability, oral bioavailability of sublingual buprenorphine is approximately 30%, so we're looking at a 3-to-1 conversion, roughly, from oral to injectable buprenorphine. So 3 milligram would be the equivalent of 9 milligrams, 8 to 9 milligrams of sublingual buprenorphine. There it goes again. And 6 milligrams would be the equivalent of about 16 to 18, and 9 milligrams would be quite significant dose. We were looking at 27 or thereabout. So people would be on day 1, they would start on 3 milligrams and they'd be stabilized on that for 7 days. During those first 7 days, people can have access to oral or sublingual buprenorphine in case the dose does not hold them. On the second week, people would be increased to 6 milligrams, and on day 22, after 3 weeks, people have a choice. They can either go up to 9 milligrams to give that a go, they can stay on 6 milligrams, or if they want to, they can reduce back to 3 milligrams. I need to go back. Yes. So that was the titration stage. Following the titration stage, there will be a maintenance stage of about 5 months. Although we call it maintenance, those changes will still be optional. At the end of the 6 months, if people have done well and they would like to continue on injectable buprenorphine, then there is an option for them to do so for 2 months. That is their choice. If they haven't done so well, then that will not be available as an option. Prior to as I said, people would be attending daily. As part of the daily routine, there would be some monitoring involved, and as the staff in this clinic has been involved in the treatment, injectable opioid treatment for many years, they would proceed to complete a routine check prior to administration to ensure that it's safe to go ahead. And this will also include inspection of injecting sites. Additionally, there are monthly key worker and medical reviews. They are alternating, so therefore there will be a comprehensive review every 2 weeks. Extended monitoring. As part of the trial, there will be a 2-hour observation period at day 1, 8, and 183, where physiological and cardiorespiratory measures will be completed and collected. Also, at each dose change in the maintenance stage, or when there are concerns, there will be extended monitoring. I'm going to take you through some of the outcome measures. We'll be looking, first of all, first outcome, reduction in street heroin use. Successful outcome is defined as 50% reduction, and treatment retention is defined as higher than 60%. The drug effects will be monitored by completing opioid withdrawal scales, visual analog scales, particularly for perceived negative or positive liking, perceived effectiveness, and experience of cravings, and a short-form research center inventory, particularly to measure euphoric effects. Safety, monitoring of adverse events by symptoms checklist, inspection of injecting sites, biochemical, hematological, hormonal, and respiratory parameters will be monitored, and I'm not going to take you through all of that. There we are. Attitudes and perceptions of injected buprenorphine. This is something we're particularly interested in, to see whether people actually rate injectable buprenorphine as a treatment. We'll be completing injecting drug users' quality of life questionnaire, lead dependence questionnaire, and there will also be qualitative interviews regarding reasons for continued documented illicit drug use, if applicable. At the end of the trial, there's 3 options available for people. They can either continue injectable buprenorphine, that is as long as stocks last. Alternatively, they can transfer onto injectable diamorphine and sublingual buprenorphine, or they can transfer back to oral sublingual buprenorphine. Obviously, if people have not done well, then it's a clinical decision as well at the end of the trial. That's what I was actually trying to say. And where are we now? Yes. The study is supported by Action on Addiction, National Addiction Centre, King's College London. Co-sponsors are King's College London and the South London and Maudsley NHS Foundation Trust. The chief investigator is Dr. James Bell, the South London and Maudsley NHS Foundation Trust. And my name is Rob Vanderwaal. I'm the research coordinator at the South London and Maudsley NHS Trust. Thank you very much.